So as a kid, I was bullied. I felt left out of games and invitations. As an adult, a lot of discrimination. I've been interviewed for jobs and passed over and given the promotions to someone equally qualified, but slender. And in dating, in the dating world, I seem to be ignored because of my size. And as far as like auditions for acting, I've been asked personally like to audition for something, and then it's given to someone who's slender. I've walked into stores where they don't have my sizes, but I'm given looks like, "What are you doing here?" And I'm ignored. They don't come and help me. I feel like our culture has made skinny as more beautiful.
Mika, has the way that some providers treated you made it more difficult for you to trust other providers and their journey supporting you?
Yes, I've shared with doctors like my efforts in trying to lose weight, and I feel ignored. I also feel judged when they accuse me for being overweight, and that everything that happens to me, any diseases or illnesses or ailments, everything's blamed on being overweight. And there was a doctor who I felt scared because he said, if you don't lose weight, you're going to get diabetes, you're going to get this other disease. And one time a doctor did tell me to take personal responsibility for my weight loss without hearing any of the efforts that I shared with him. He said that if you don't get serious about your weight loss, you're going to have a short life.
You know, I think it's really unfortunate that many of our patients have negative interactions with their healthcare providers, our patients with overweight and obesity. For sure, our studies have shown that providers spend less time with patients who are overweight, may even not counsel them because they don't think that their education is as high or that they're maybe just not motivated. And there's this implicit bias that our healthcare providers have when even interacting with our patients with obesity. What's your experience with this?
Yeah, definitely bias and stigma. That's a hot topic out there in so many areas, but definitely when it comes to body weight and obesity. And we know that healthcare providers do have bias. It's there. It's intrinsic to some degree. And so being aware of it is kind of the first step. I always say, be aware of it, and then think about how you interact and the things you said. Are you addressing the problem the patients come in for, or are you immediately talking about just about their weight or not doing what you would do for another patient that maybe does not have obesity at this point. So just being aware of it, knowing that it exists. The thing about bias is we don't necessarily think we have it, but we do. When we test for it, it's there. And so being aware of it is always that first step, because if you're aware of it, then you can be conscious about how you're going to deal with it, things you're going to say, how you're going to interact with patients, knowing that you have that.
I think it's really important. About 2/3 of us have that bias, right? And so it's about recognition, but it's also about actions. And you've spoken a little bit about how you would address that with the patient. Make sure you spend adequate time. Make sure you address the specific issue that the patient comes in with. So I think it's about recognition, but it's also in those actions that you take in the care of the patient. And there is an opportunity to address their health issues. Obesity happens to be one of them, but addressing all of the health issues that they bring to you for an intervention or that they need help with, I think is a key component.
Why do you think that women have more stigma kind of around this than men? I think it's probably true, right? Why do you think that's the case?
There's a big society effect on it, don't you think? I mean, the images in the press and the certain body type that they're supposed to be. Right? I think there's a lot of society pressure on women to fit a certain body type. And one of the big things I like to discuss with my patients is, let's not discuss just weight. Let's look at the overall. What is your goal? I try to address having, our goal is to improve your health, right? And so, yes, your weight is affecting your health, but our goal is to improve your health. And setting those kind of SMART goals helps people to pull away from just thinking only of a certain image in their head.
Right, and I love that idea, and I've been moving that direction too. I used to be, all right, I'm going to bring up your weight because it's a vital sign and it's important. Just like I would bring up blood pressure, I'm going to bring up your weight. And while I still believe that, I also think then we have to kind of move toward being a little bit broader, that it's not just about weight, that there are other health behaviors and other lifestyle behaviors that we can talk about. And so it's about weight, and yes, it's about your fitness level. Yes, it's about your sleep. Yes, it's about nutrition. So I can be a little bit broader, and I can tend to meet the patient where they are. So it's not just about weight, it's about weight and some other things that really are all interrelated, right? You know, if they're willing to work on fitness or their nutrition, and maybe they don't want to talk about weight, that's okay, because you know what? If we're working on nutrition and fitness, it probably is going to have a little bit of an impact on their body weight. And I know it's going to have an impact on their health, which, like you said, is really what, as healthcare providers, we're trying to do.
It is threading that needle, though, right? Because for sure we are trying to improve health, but we know that the more weight that they do lose, the bigger the effect. So it's true that the more weight they lose, the bigger the effect on their health, but not everyone is going to get to a BMI below 30 before they become pregnant. And so, how do you counsel your patients who want to lose weight before getting pregnant?
Well, we would love to maximize weight loss, but even as we talked about before, even a moderate amount of weight loss may infect a lot of the diseases that are adverse for the baby and for the mother in pregnancy. So again, I think it's this issue of making small changes. One of the other places that I see that bias comes in is that we make assumptions about our patients with obesity that they will automatically have some of these other diseases when in fact they may not actually have it. And as you say, it is about threading the needle, right? It's about trying to figure out where there are opportunities, which often happens at changes in the life cycle for women, to have the discussion, but also not to make assumptions about other diseases that they may or may not have just because they have obesity as a chronic disease.
Because there is a subset of people that are what we call the metabolically healthy obese. They have obesity, but there's no metabolic changes at this point. Now, we all know that it's an odds game, and you follow people over time, they're at an increased risk, and over time may develop that. So it does not mean that they're not at risk, but at this point, they may be relatively healthy from a metabolic standpoint. I always also talk about, though, functionally, as you gain weight, you start to have back and knee and foot problems. So there's lots to that. But I think you make a really good point. Not everybody walking in has all of these conditions that we're talking about at any level of obesity. I've seen it when I was working with people who had extreme obesity. A lot of them were metabolically healthy. They didn't have type 2 diabetes. Like I said, that doesn't mean they weren't at a higher risk, but they didn't have that. They did have some of the back and knee and problems like that. So I think it's recognizing that, and that one size doesn't fit all, and you're not just automatically going to put someone in that category.
I think the other bias many providers may think is that, I'm going to bring this subject up because they don't know that it's a problem. And we know that most patients have tried to lose weight or several times, 7 to 8 serious attempts before they come and seek help from their provider. So this assumption that, it's something that they don't know. Patients with obesity and overweight, they know that it's an issue, and most have made serious attempts at losing weight and actually would like the conversation brought up. So I think the bias of...
Yeah, I think 10 years ago, it was a little bit more about educating between the relationship between extra body fat and comorbidities and talking about obesity as a disease. That 10 years ago. I think now the message is out there. I think most people do know I have some extra body fat and this is what it leads to. We can always educate. We should always continue. But I think I make the assumption they do know that, and that I'm not telling them something that for the first time, because that comes off being kind of condescending and perhaps not in a good relationship builder, at least, when you start to talk.
So what are some of the key things that you try to do to help our patients with this interaction? I know one is the terminology we do, right? I mean, not using the O word. Some patients don't like to, when we do studies, patients don't like to be called obese, or especially obese as a description.
Yeah, Yeah, there's whole kind of how does that interaction occur? One of the big things that I've started talking about, this is relatively new for me, is, as we start to say that, yes, there's a wide variety of body sizes and shapes that we should be including everybody, kind of this inclusive language that we're using in recognition of that, is to talk about, that body weight is not, or losing weight, or what weight you're at, your body shape is not related to your happiness or what you're wanting. Really trying to untangle self-love and happiness from anything to do with your body state. So many times patients come in and it's very conditional. I will be happy when I lose weight. I will love myself when I lose weight. So we need to untangle that and say, no, happiness and body weight and body state are not necessarily related. That unconditional aspect of it has really been helpful to say, let's untangle that, because that's why it's so messy. That's what all that stigma is in there a lot of times, and that bias is kind of sitting in there. So really working on this is, yes, you can work on your body state, weight, lose weight. I'm already using terminology. You can hear the terminology I tend to use, sometimes staying away from the O word to some degree. And you want to lose weight. You love yourself. You don't want to lose weight. You love yourself. It has nothing to do with loving yourself, right? That is unconditional. You love yourself. You're happy. Not related to that body state. And I think that's an important idea to start getting out there, because now there's people who say, you know what, I shouldn't lose weight, because if I lose weight, that means I'm not accepting my body. I don't think that's true either. I think we need to start kind of thinking of them as separate issues.
So when I go to the doctor, I feel embarrassed to bring up my weight to them, because as being 190 pounds, 4'11", do I tell them my weight, or are they the ones that are supposed to talk to me and advise me on what to do, since, I am overweight? At the end of the day, who should be bringing up those conversations, me or my doctor?
Over the years in my practice, I have just been shocked when I bring up the discussion around weight with my patients, that I'm the first one to bring it up with them. And they've seen doctors for years and years, and that hasn't been brought up. Has that been your experience?
Yeah, a lot of people come to me because they want to talk about their weight. So I may have a little bit of a bias, because a lot of times they know what they're coming. But what about you?
I know my colleagues often tell me, well, especially male colleagues, I don't want to bring up their weight, because then it's going to be like I'm judging them. And there's some apprehension about bringing up a patient's weight. Interesting, when we do surveys with patients with obesity, 2/3 of them say they would like their healthcare provider to bring it up. So I have experienced the same as you. Many patients say, my doctor, my healthcare provider never brought it up. It's I think more important how you bring it up and when you bring it up. There is a skill, right? I think back when providers tell me I'm afraid to bring it up, well, think about the first time we had a conversation about a terminal illness. Probably our first time was not the most eloquent. It takes practice. We talk about this confines of the 5 A's, where you could ask a patient, is it okay if we talk about your weight today? As an obesity physician, of course we're going to bring it up. I think often, do I say, can I bring up your diabetes? Can I bring up your blood pressure? But when we survey patients with obesity and really the negative interactions that they've had with their healthcare provider, it's really made me step back and say, I think it's worthwhile to ask. It brings up an empathy. It brings up a feeling of inclusiveness, that I'm interested and I'm respecting your decision to say, you know what, I don't want to talk about it today, or okay, but I do think the problem you're coming in today is related to your excess weight. I'd like us to discuss about it. So maybe another time we can schedule an appointment and discuss it. Primary care, that can help that interaction.
Yeah, I think asking is good, and then it sets you up for, let's say they do say, I really don't want to be weighed today. You can then explain why you're thinking this would be a good idea. And I think that's a lot of times what the patient wants, if they feel like you're just automatically weighing them for no reason versus no, there's a real reason why I'm weighing you today. I think that goes a long way, and asking them is a way. I used to be completely against that. And so there's probably videos of me out there saying, no, I don't ask you, do you want your blood pressure checked? I don't ask you, for this or that. And so I was very firmly against that because I felt like it was a vital sign, and I felt like it was a piece of data we needed, and I felt like we were giving too much, making it different than that, and it shouldn't be. It's a disease, and we should treat it as such. But I've changed. And I now think there is a lot of baggage associated with weight. There is a lot of experiences that have been negative around weight. There is a lot of other stuff that makes it different than blood pressure. So I've switched and said, I think it is a good idea to say, can I talk about your weight today? May I weigh you? There are cards out there now that say, don't weigh me unless you talk, you tell me why. That's where our patients are. We may see it as a vital sign. We may just see it as a piece of data, but they don't. And so meeting them where they are, that's kind of where I've moved to say, okay, this is what's important to them. So asking them, can I weigh you today? Can we talk about your weight? I think is something that I've decided is probably what we should do.
I think, the patients, in my experience, have been very grateful that you brought it up. It may not be something that they want to address at that time, but it seems like it's sort of it creates some stress in the room because they know it and you know it, and it's not something that's actually discussed. And so normalizing it as a chronic disease process, I think, is important. The other thing in my field is that there are certain times in a woman's life cycle where they're really ready for change. Sometimes that's in the preconceptual period. Sometimes it's during pregnancy, postpartum, the menopausal phase where there's just a readiness point. And so it's a really opportune time to bring in, the discussion and to ask the questions. And so it's really about asking if they're ready to have that conversation and, sort of some motivational interviewing strategies to really assess that readiness and whether it's the right time to have a conversation.
I agree. When they're either trying to get pregnant or they've just become pregnant, now it's about something maybe that's a little bit bigger than just themselves. That can be a moment when they want to talk about it, so that might be a great opportunity. I mean, I don't know if you see that. What are the times when maybe they're more open to or really wanting to talk about weight?
We see that in the families, actually, not even just in women, and it's really around that peripartum state primarily. So conception, pregnancy, postpartum, because it's a new phase and a new time in their life. And it isn't necessarily confined either to a first pregnancy. It can be any time, really along that continuum.
Choosing the time, I think, is important, right? When somebody is in acute pain from back pain and we know that it's related to their weight, but that might not be the best time. I think in primary care, the annual physical is definitely some time where we're always looking at a lot of data, like data points, as you said. So I really like to look at weight trends. And so I think it's a good opportunity for a primary care provider to say, hey, I've been noticing this trend in the last few visits, and that may also take some of the pressure away from the provider that I'm just only looking at your weight. Right. So I'm looking at a trend, and the trend is concerning to me. Can we schedule another time? And then schedule a follow-up appointment. Yeah,
because at that point, it's not about a number. I think, they have this number in their head, and there's a lot of emotional stuff that's associated with that number. Now you're not even bringing up a number necessarily. You're bringing up a trend. So I always say, yes, I, as a healthcare provider, I do look at body mass index. I do look at waist circumference because that says, body mass index says there's potentially too much fat, right? The amount of fat. Then waist circumference says, well, there may be too much fat in an area that we know increases your risk. And then the third thing I always look at is this trend. And I think a lot of people don't do this, to say, what the last 3 times that you've been in here, where are we staying the same, going down, going up? And using that as a way to start talking about it, I think is really, can be really helpful.
Well, you would never talk about any other chronic disease with one data point. You would only ever deal with the changes over time. Hypertension, diabetes, following hemoglobin A1Cs. I'm not quite sure why we've arrived at a different point. And so I think that sort of normalizes obesity as a chronic disease for patients.
The other reason I like to look at trends is I don't know how many times patients have told me, we've been working on weight loss, and they go and see their specialist and they go, oh, your weight is elevated, you need to lose weight. And the patient said, I've lost 40 pounds. I have been working on it. So I think it's important to look at trends not only going up, but also trends going down, because that's a great motivator when a provider can say, hey, what have you been doing? This is a great thing for your health, and I'm seeing the results in the other numbers, and your weight program is working.
So Dr. Luke, you told us a lot about that you have improved your questioning in primary care over time based on your experiences, right, and learning. Are there some pitfalls that you would recommend that we avoid?
Oh, I definitely, I think the important is the whole environment and the whole experience that my patient has. And so I agree with Dr. Wyatt talked about the whole weighing experience. So I really talk to my providers about focusing more on health and not just the number when we bring them into the office. I also try not to use the word obese in it as a description. I really think of it as a chronic disease. And so I try to get my staff to not use that word as a description.
I've been moving toward body state because I think of a state as something that changes over time. Mm-hmm. We talk about traits and states, and states are something that evolves, different phases of your life. There may be a different body state that's appropriate when you're pregnant, right? That's a different body state when you're not pregnant. And a lot of things kind of go into body state. So I've been using that terminology a lot in place of weight or obesity, talking about body state. And I love one thing you said. I think when a patient comes in and they're in pain and they're in acute illness, that to me is not the best time to bring up weight. Help them with their pain, help them with their acute nature of what's going on, and then there may be an appropriate time. So you said, if they come in with this earache, not the time necessarily to bring up their weight, in my opinion. There will be better times that perhaps you can mention that or ask to mention it.
One of the things we were discussing was now patients have access to their whole medical records. And some of the big ones I don't like is patients of ours that have class 3 obesity, and on the diagnosis it says morbid obesity. And that really is providing judgment, and there's a lot of bias in that word. I do my best to make sure that gets removed from their chart and putting it in as class 3 or stage 3 obesity.
Yeah, that word is an old word. We need to get rid of that morbid part.
Unfortunately, it's still in our ICD-10, so there's actually effort to remove it. And the other diagnosis is morbid obesity due to excess calories, right? And so those are things that we all need to advocate to get removed because it contributes to this weight bias to our patients.
Totally agree.
My daughter is graduating from college this summer, and so that means lots of pictures, lots of family pictures. I've told my doctor I would like to lose 20 pounds before then. That'll be in June. So do you think that would be a realistic goal for me to lose 20 pounds by June? And if so, what would be our ways to go about that?
I have patients that come into the office that have just really unrealistic expectations. They'll have a life event coming up, or they want to reset to a completely normal BMI in an unrealistic time frame prior to conception. One of the things that's been difficult for me over the years is working with patients on short-term strategies and long-term strategies. Because obviously women tend to regain weight after they lose weight. And so what are some tips that you guys use in your practices when you are working with patients to establish both those short and long-term strategies?
Yeah. First of all, I love that you're thinking about short-term strategies and long-term strategies. I think that's one of the most important things for long-term success, that we think about weight loss as being relatively short-term. You can't be in weight loss forever. It's a defined period of time, because you can't lose weight forever. If you did, you would die. So you lose weight for a certain period of time, and then you need to be ready to move into what I call weight loss maintenance, which is different than what you were doing before you lost the weight, but not exactly the same as what you do to lose the weight. So starting to think about shorter, strategies for weight loss and long-term strategies for weight loss maintenance is one of the things we saw in the National Weight Control Registry was associated with success. So I think of them separately, and I actually talk to my patients. We can have some short-term goals. We talk about what is realistic in terms of weight loss. I usually say 1 to 2 pounds a week, or I use something called the 1% a week goal based on your starting body weight. What's 1%? So if you weigh 200 pounds, that would be 2 pounds a week. If you weigh 300 pounds, that would be 3 pounds per week. Now that's pretty aggressive. That's a pretty aggressive goal, but most people come in and are wanting aggressive goals a lot of times. And so I want to kind of meet them where they are, but I don't want them to think, oh my gosh, I can lose, 50 pounds in 4 weeks, which is just physiologically impossible. So I do work on appropriate goals, but I really like to think about weight loss being separate than weight loss maintenance. And the strategies and tools we set and the goals we set for weight loss are different than the tools and strategies and goals that we set in weight loss maintenance. I always say weight loss is sexy. It's fun. I mean, if you're successful, right, you're buying new clothes, people are saying, what are you doing? You look great, you're feeling good, right? Weight loss maintenance is like watching paint dry, No one walks up to you and says, wow, you look exactly like you did a month ago, And so it's a very different process, and you've got to kind of set up different motivations, different goals. What does success look like? But I think people never move into weight loss maintenance. They stay in weight loss too long, and they don't have a plan and strategy for weight loss maintenance. And that's one of the biggest reasons why they regain the weight, or a reason why they regain the weight.
I think also I like to acknowledge their short-term goal. Okay, I see that you want to lose this much by your son's wedding, but I also try to educate them that the number of pounds on the scale is not necessarily in your conscious control. The reason I prefer my patients not to have a strict number as a weight goal, because if they don't meet that goal, this is often when they cancel their appointment. Oh, I was supposed to lose 2 pounds a week. I didn't lose 8 pounds this month, so I canceled my appointment, right? And instead of thinking about, okay, it's great that you have this short-term goal, but you only have so much control over that. So let's set some other measurable goals that you have control over. And we're going to try to get as much weight off as we can. But know that your body, it controls a lot of that as well. And so we're looking at both the short term and the long term, because I want to be your doctor for life. And so I want us to have a plan of sustainable changes that we can make so that we can keep going. The other is when we are in that weight maintenance, you're right, it's not sexy, So when patients don't lose weight, oh, I didn't lose another 2 pounds. I'm like, you didn't gain weight. That is a huge success. And when you reframe it that way, many times like, oh, I'm so glad. I thought you were going to be so upset at me, because I didn't lose more weight. No, it's thrilling. You are successful by not regaining the weight, because we actually expect some of that weight to come back on. You're right. The weight doesn't just go down in a straight line. We have plateaus. We have little weight increases, and then we may see another weight loss. And this is an expected course in weight loss and in weight maintenance. And that kind of unloads a little of these expectations. And
they may
then
not have thought about it that way. And that's where, and I love what you said about multiple goals. So I do set weight goals because that's what my patients want. A lot of times they're coming to me for weight loss. So I do set weight goals if they want to, but I always set some other goals too. So I'm kind of giving them what they want and sneaking in some other goals that I can use. So I love the idea of multiple goals. Love the idea that, kind of meeting them where they are though, I don't want to pull the rug out from under them. So if they come in and they're like, I want to lose 20 pounds for a wedding. Now I could just say, well, that shouldn't be why that's not possible, or that shouldn't be, the reason that motivates you. But they're coming to me. They're motivated at that moment. So I'm going to work on it, but I'm going to let that sit for a little bit. I'm not going to just shoot that down. Because if I shoot that down from the very beginning, then I haven't created a relationship with them. So sometimes I allow that, knowing that I'm going to deal with that as we go, knowing that that may be unrealistic, or knowing that that goal alone may not be enough for long-term success, because that's an external motivator, and when that wedding's over, what is typically going to happen? But can I start working on intrinsic other goals and other things while we're in the process? The other thing I love to do is I tell my patients this, every single one of them. When you always want to come see me when things are good or when they think things are good, I want you to come see me when they're not. That's when I can help you. When you don't, when you haven't lost the weight you think you should lose. Maybe I'm going to talk about that, the appropriate, what does weight loss look like? But that's when I can be of most assistance when you're struggling. So that's when I want you to show up. So actually telling them that, I think gives them permission to say, I'm not looking for success. I'm actually looking for you to come when you're struggling, and they're more likely to show up then.
I couldn't agree more. I congratulate them. Just by coming today, we're continuing on our goal, right? So whether our plan didn't work, well, this is why we're here. Right. I'm here to help you. Let's brainstorm some other things. We didn't make it to the gym 3 days a week like we want. We didn't hit our 10,000 steps. So this is when I can be the most help. So just by showing up, you are showing that you're committed to this long-term plan.
To me, it's about this individualization related to this multifactorial disease, and, also allowing the patient's engagement in the goal setting so that they take some ownership actually of the goals as they go through this process with support and reinforcement, to address this in sort of a multifaceted approach.
I think that's the only way it works, and that takes some skill, that takes some practice. Like I said, that's the art of it. But when you get good at that, that is when really things start to click. That's when you can really, really help that patient down their individual path when it comes to weight management.
So, Dr. Wyatt, I do think that the bias against women and their body type really affects even how successful they are with weight loss. I know I have many patients who don't go to the pool or don't go to the gym because of shame of the way their body looks. And so it's this cycle of this pressure to look a certain image really affecting their ability to have that image. Yeah. And so do you see this? I think that there's a difference with saying, to loving my body and still wanting to have a better body image.
Yeah, and I say, it's whatever motivates someone. That's you got to figure out what's going to motivate that patient. And if you want to look better, that's okay too. It doesn't have to all be about that, but if that's what's motivating you, then I don't discourage that. Who am I to tell someone what motivates them and what's right or wrong, that judgment? It may not be what motivates me, I always say, but let's make sure we're not judging, what motivates me and what motivates my patient. Let's figure out what's motivating my patient. And I see what you just talked about all the time, people waiting. Well, once I lose the weight, then I'm going to go to the pool. Then I'm going to experience this in my life. Then I'm going to be happy. Then I'm going to get to go climb this mountain, or then I'm going to get to go do this with my kids, or then I'm going to, travel the world, whatever it may be. And one of the keys that I found to getting people to be successful is you start doing that now. You still set your goal if you want to lose weight. That's fine. But you don't wait for the weight loss to feel that way, for happiness, for joy, for experiencing life. Actually, by going out there and being happy, experiencing life now, it moves you towards your goal. It helps you with your goal. It's part, to me, of the solution, the plan to be that. And that it doesn't have to be, you're not waiting. And I think that's such an important thing. I see that all the time. So I spend a lot of times with patients saying, why do you want to lose weight? They say, because I want to feel this way, live this way, I want to be happy. Okay, what can we do right now for you to be happy? Let's not wait. Let's start being happy. Let's talk about a few things you could do right now to experience joy or happiness. Let's start doing them now, and let's start moving toward weight loss.
You can still love your body and want to improve yourself.
Yes.
Right? Yes. And the two are not separate.
And I think social media has started to kind of push some messaging out that if you decide that you do want to lose weight, if you do want to change your body shape, that you don't love yourself. You don't have to change your body shape. But you could. Once again, it's about separating the two. When is loving yourself related to whether you choose to change your body shape because you want to, or whether you choose not to? I think we have to stop being so prescriptive and judgmental, and it can go either direction.
So it's really about goal setting. Yeah. And so as a provider, understanding what your bias is, and I think being aware of that will help you work with the patient to set an appropriate goal. But it is about that recognition for providers as well. So the goal can't be just to lose weight. The goal has to be what the patient's goal is, and that might be a benefit
Yes.
of the goal setting.
Getting that internal drive for that patient, what is really going to motivate them long term to make some of these behavioral changes so that we know are required for long-term weight loss, and then not judging that. I think as healthcare providers, I see we're all about health. We went into this field because we're about health. It's pretty important to us, or we probably wouldn't be a healthcare provider. But that isn't always what motivates our patients. In fact, I would say a lot of times that's not the biggest motivator. It may be a secondary motivator, or it may be a motivator, but it may not be. And I have to be really careful that I don't take my bias about what's important and force it on my patient, because it doesn't work. It doesn't motivate them. And so what you said is me being aware, this is what motivates me. This is what I get fired up about. I need to figure out what my patient gets fired up about. And I need to be careful not to judge that, to, say, oh, that's not a good one. You want to fit in a little black dress? Ugh, that's so superficial. We may not say it that way, but we kind of dismiss it that way. Oh, getting in that little black dress may be tied to something that's super important to that patient. And you know what? If it's super important to that patient, who am I to say it's not important?
I think it's also important to tell them the weight bias is not from the healthcare provider only. It's really in the patient as well. Often patients come to me like, ugh, I almost canceled my appointment because I was so bad this weekend, or my food was so bad. And I bring up, I hear judgment in your voice. I hear that you're judging yourself for what you ate last night. And that's not what we're here about, right? Yeah. I don't judge what you're eating, and I don't want you to judge what you're eating, right? We have what is our goal? Our goal for me is improving your health. Your goal may be to be a healthier person, have a better body shape or a lower weight. And that's our goal, not judging ourselves on, I ate poorly or I didn't do what I was supposed to do. Let's figure out how can we make a plan that's going to work for you. Yeah. What can you do? What smaller thing can be more attainable, right? If it's about never eating pumpkin pie, that may not be a solution.
And I love what you said about the scale. I think when they get on the scale, that's a prime time to train your staff and yourself. I actually weigh my patients because I think it's a time when I can have that interaction and look for that judgment, make sure I'm not judging. I don't say good or bad based on whether they've lost weight, gained weight, or stayed the same, because what am I doing? That's kind of setting a judgment. To me, it's a data point. It doesn't reflect anything that they've done. I mean, whether they're good or bad over the last day, that stigma attached to it. So I really work on making sure that weighing them is non-judgmental, that we really work on that in our office.
It seems like the judgment piece is, and understanding the bias, is learning to take care of patients that are overweight and obese as we would any other chronic disease. So instead of it being a sort of yes, no, good, bad, it's a data point, as you say, in the progression of taking care of somebody with a chronic disease.
Yeah.
So Dr. Luke, you talked about the patient that was only, wasn't able to meet their 10,000 steps. There's other barriers that I think our patients face. When you're goal setting, how do you address some of those barriers around, food insecurities and socioeconomic barriers? What are some of those other elements that affect their ability to meet
whenever
their
I'm setting
goals?
a treatment plan, I really try to get the patient to be involved in the process. I think when we have this type of shared decision making, it's more effective. And so, for instance, with the 10,000 steps, I will bring that up and say, so what were the barriers that we didn't meet those 10,000 steps? How can we improve that? Maybe, I ran out of time is a classic one, right? So where can we fit in time throughout your day? Or, and that's also when I try to get them to be very specific on our plan. And so then that's how we can find the barriers. An eating plan, an often one is, I don't have time to go to the grocery store, or I couldn't afford fresh vegetables this week. And these are actual things that we may not think about as healthcare providers. Oh, you should be having 5 cups of fruits and vegetables a day. Well, it's expensive, and it's hard to get to the grocery store for many of our patients. So food insecurity is a big one. Time is a big one. There are many obstacles to having this perfect intensive lifestyle intervention. And so I strive to tell them, I'm not looking for perfect. I want to know what you can do today, right? So let's try to look at, maybe we're not going to hit 10. What could you give me? And there's where that art of negotiations. All right, let's take a look. I see you have that fancy Fitbit or watch on. What are you averaging? Let's just say you're averaging 2,000. Do you think you could get 3? And they get specific about that. So really trying to find where they're at.
Yeah. Yeah, I think the barriers really speaks to this individualization, right? Because there's so many different barriers and certain individuals will have them, and you don't know necessarily at the beginning which barriers are going to come up when, and that's part of what you kind of uncover as you go down this weight management journey with the patient. And I like to think about barriers, I always say they're learning opportunities or experiential learnings that are naturally kind of brought to you. And you didn't get your exercise minutes in. We talked about that was really important to you. You weren't able to do it. Why? Let's really get into why. Is there a pattern? And then what could we do to make that reason, the why, that you weren't able to do it easier next time or not as likely to occur? Let's be really strategic. So to me, barriers are a perfect opportunity to be very strategic with the patient, to problem solve, to not have regret. I always say, you didn't get it. Don't go to the regret side. Go to the learning side. So yeah, this happened. What will I do different next time? What little routine could I put into place that would make that not likely to happen? I didn't get up in the morning and exercise. You know what? I got up and my clothes weren't washed and they were all, okay, could we get into a routine of putting out your exercise clothing the morning before? Let's try it. See what happens. If it didn't help, okay, let's problem solve again. But that to me is the key, and you don't know that up front. You learn that as you go along, and it's about that partnership with the patient.
I love that because it really takes the judgment away from not hitting that goal and instead making it, as you say, an opportunity.
Yeah, and I love that word. It's opportunity. There's a possibility here. Let's really fine-tune this to what you need and what my patient that I saw 10 minutes ago needs, and the barriers for them are very different than what you need and the barriers you're facing.